and go.
I just wanted to begin by welcoming our two seminar speakers today, doctors Er- uh, Emily Mositis. Is that correct? Is that close?
It's perfect. That's exactly right.
Okay, and Ashley Meehan. And the reason for this topic today is that homelessness is an incredible problem. Obviously reflects on health and healthcare, and the fact that it is less than optimally recognized and is of increasing significance. I thought it was really important to hear from two people who have been making a difference in that key area. That's all I'm going to say because they're going to go ahead and to tell us about the problem itself, how in fact it's being dealt with, some of the challenges and opportunities. And I guess all I want to conclude my introduction with is a statement of thank you so very much for joining us.
Thanks, Gary. I want to echo the thank yous to our two speakers for being here today and for all of our audience members who are joining us. It's my pleasure to introduce our two speakers. So our first speaker is Emily Mositis. She is Vermont's new state epidemiologist for infectious disease, and she served as CDC's subject matter expert on homelessness and infectious diseases during the COVID-19 pandemic. And our other speaker is Ashley Meehan, who recently defended her PhD dissertation at the Johns Hopkins Bloomberg School of Public Health, and she has worked with both the CDC and the U.S. Department of Housing and Urban Development to bridge public health and homeless service sectors. And today they will discuss the health risks related to the context of homelessness, recent shifts in the landscape of homelessness, and opportunities to support health among community members facing homelessness. So I will turn it over to you. Can't wait to hear.
Thank you so much. Thanks for the warm welcomes. And we're really glad to be here talking about this subject that we both think is incredibly important. And Ashley and I are sharing this presentation because even though I'm newly the Vermont's state epidemiologist for infectious diseases, I'm mostly speaking from my prior role as the subject matter expert on homelessness from CDC. And Ashley is now in that role, so has some more insight into that space now. But she's mostly speaking from her Johns Hopkins role, where she's been doing research in this area. So we are going to tell you a couple stories and share some data on the national scale. And then we're also going to dig into regional data. And the purpose of our talk today is to paint a picture of why we need to be thinking about homelessness and also where the opportunities are for supporting our community members who are experiencing homelessness. So this is a landscape presentation. We're not going to dig very deep in any particular topic area, but we're going to touch on kind of the picture here and happy to answer any specific questions that you might have at the end. So I will start with a story. Ashley, you want to go to the next slide? And the story is set in Alaska, of all places. That's not very nearby. But this is the origin of how I started working in this area. I'm an infectious disease epidemiologist. I had been working in global health, and after my postdoc, I was placed in Alaska to work on invasive diseases or invasive bacterial diseases, mostly among Alaska Native people in Alaska. So about 2 days after I got there, we were reviewing data on invasive bacterial diseases, and we identified two cases of a rare subtype of group A streptococcus in people who were experiencing homelessness in Fairbanks, Alaska. At the time, my supervisor said something really offhand like, "Oh yeah, we get repeated various outbreaks in the homeless population." And that statement stuck in my brain, and it is still stuck in my brain because I thought at that time, I thought, what, so you see that there's a problem here. Should we do something about that? Maybe we could try to stop them or prevent them. Maybe we could go upstream a little bit. But anyways, it turned out that those two cases of that rare type of invasive group A streptococcus turned into one of those outbreaks that my supervisor had mentioned. So Ashley, if you want to go to the next slide. We ended up with a large, severe outbreak of invasive group A strep, with a high percentage of necrotizing fasciitis, amputations, and deaths. In among people experiencing homelessness, the outbreak had shifted from Fairbanks to Anchorage into some of the primary shelters in Anchorage. And I spent the better part of a year tracking this bacteria, trying to stop it from spreading. I was in the shelters every day. I learned so much about the context of homelessness and how we need to shift the way we think to be able to effectively protect people from disease in this context. So, Ashley, go to the yeah, so we had three failed attempts to interrupt transmission for this outbreak. First thing we tried was contact tracing and chemoprophylaxis. This is a common approach. This is what we use when we respond to invasive group A strep. Um, no impact. There just continued rising cases after attempting to do contact tracing. Very hard to do contact tracing too among people experiencing homelessness. You can go to the next one, Ashley. We tried to screen everyone in the shelters and treat anyone that was colonized with group A strep, and that again had no impact on transmission because we just weren't able to catch every person that might have been colonized. It continued to spread. And then we also attempted to roll out chlorhexidine wash at showers so that people could decolonize their skin. And this was just logistically very difficult to accomplish. We weren't able to roll it out very effectively. So none of this was working in this situation. And what we ended up doing was, go ahead, Ashley, you can. We ended up doing a mass antibiotic administration of a single dose of azithromycin to just try to knock down this bacteria. We would not do this in pretty much any other situation. And so it took a long time to come to this place of recognizing what might work here. And it appeared to have worked. So after the administration, we had only a single case, and that person had not received antibiotics. We provided antibiotics. We had a team of nurses and physicians and pharmacists going to the shelters over the course of a week, providing antibiotics to over 300 people. And we did what we set out to do, which was knock down that bacteria. But what I learned in this process was that homelessness is an acutely dangerous context, and we have to shift the way that we think about protecting health in this context. So actually go to the next slide. Thanks. So after the outbreak, we had a chance to take a step back and say, okay, that was an outbreak. We hear, that there's these repeated outbreaks. What about just baseline? What about we have baseline invasive group A strep in the population, and we know it crops up and we keep track of it. Well, the baseline risk of invasive streptococcus infection in Anchorage at that time was 7 to 53 times higher for people experiencing homelessness than the general population. This is removing cases from the outbreak. So this is just, from 2002 to 2015, this was the baseline. And those types of risks, that risk level is just incredibly high. I'm sure we have, people that look at relative risks and are epidemiologists here and know that you don't really see relative risks that are so high. So just really incredibly high. And the underlying risks that we see here it's just different for people experiencing homelessness than for the general population. So this was about 10 years ago, though. So what is happening now? Let's take a look at some national numbers. We'll zoom forward a little bit and look at the trends over time. And it turns out that the information we were seeing in Alaska kind of preceded what turned into a national trend over the past 10 years. We see this clear rise in cases of invasive group A streptococcus over time. And notably, from 2013 to 2022, the proportion of invasive group A streptococcus in people experiencing proportion of cases that were in people experiencing homelessness jumped. So a large part of this rise is attributable to cases in people experiencing homelessness. Went from 5% of all the cases in 2013 to 18% of all the cases in 2022. So let's go to the next slide. Because why don't we take a look at what is happening with homelessness? Well, these curves, looking at homelessness itself nationally, they look a little bit similar to the curve that we saw with invasive group A streptococcus. This is the point in time estimation from the Department of Housing and Urban Development every year, the way that we get an understanding of how many people are experiencing homelessness is that there's a single day count for how many people are in shelters and how many people are sleeping outside. Um, so it's required by Housing and Urban Development to do this, but they alleviated that requirement in 2021 for unsheltered homelessness. So you can see there's a gap in 2021. And then you can see that we have this really big jump post-pandemic in the counts of people experiencing homelessness up to, over 770,000 people across the US. We also know that this is an undercount. And let me just share briefly. So sheltered homelessness is considered if someone is staying in an emergency shelter or transitional housing. And unsheltered homelessness is when someone is staying somewhere that's considered to be not appropriate for human habitation. Like it could be staying in a car, staying in a tent, staying in a doorway, staying in an abandoned house that doesn't have utilities. Those all count as unsheltered homelessness. Okay, let's go to the next slide. Okay, so we know so many people now are experiencing homelessness, and so I wanted to go through what the risks are related to homelessness. What's the underlying risk context when people come into homelessness? And people come into homelessness and have underlying risks already, and then homelessness itself creates a context of risk. And these are some of the components of the context that when we're thinking about health, we need to keep in mind. One is the physical environment. People are simply in different places than people who are housed in a shelter. It can be a congregate setting where people are crowded together. Outside, people can be exposed to elements and lack water and sanitation. Access to resources and food and basic needs is just different. So it might not be that people can't access it, but it's a totally different pathway for how people are going to get to it. People's survival priorities are very different. If someone is unhoused, their survival priorities are going to shift towards safety and immediate needs and housing, and it might not be health. And in the health space, we need to be thinking about what those survival priorities are. Relationships with service providers are completely different. And that's based on, the experience of homelessness, the ability to access care, and also stigma within systems and institutions that change the relationship dynamic in both directions. We also see a big difference in demographics. People experiencing homelessness are demographically different than people who are housed. Homelessness is inequitable, it's racially inequitable, and we see higher proportions of people who are American Indian, Alaska Native, Black. We see big differences in demographics between people who are housed and people who are not housed. And then finally, displacement is an experience that nearly everyone who experiences homelessness will face. And that it comes in different forms. When we see something like an encampment in this picture, People are regularly displaced when encampments are cleared. They have to move, they get disrupted, they lose their stuff, they lose their patterns. Um, they can also be displaced even if people are sheltered. So we have shelters that are open in the winter, but not in the summer in some places. And so they get displaced whenever the weather warms up. Or even just shelters, often shelters are closed in the day and they can stay there at night, but they can't stay there in the day. So they get displaced during the day. An instability in the day to day for people who are experiencing homelessness. So let's go to the next slide. So, um, group-based strep, as I described those risks related to invasive group-based strep, it is not unique because all those pieces of the context that I mentioned create this milieu of risk that underlies risk pretty much across the board. We did a review of infectious diseases among people experiencing homelessness a couple years ago, and we wanted to understand what do those risk comparisons look like when we compare people who are experiencing homelessness to people who are housed basically across the board. You know, the risk is higher and often manyfold higher for infectious diseases. Tuberculosis, MRSA, scabies, West Nile, you know, people are outside, they're more likely to get vector-borne diseases, Shigella, STDs, and this is just a small sampling. You know, we know HIV, viral load suppression is lower. We know the risks are many, there are many more than this. Which is why we wanted to capture it in this review, and I still don't think it fully captures everything that we know. But this is infectious disease, and of course, that's where I'm coming from when I'm thinking about this. But I want to hand it over to Ashley because Ashley has done some really awesome work in other areas and has some really great federal context so that we can know kind of where are we right now related to homelessness and health. So, Ashley, I will hand it to you.
Thanks, Emily. Hi, all. So glad to be here. Like Emily said, I'm going to switch a little bit to talk more about things that we know that aren't necessarily related to infectious diseases. And I'm going to really focus on one of the more extreme outcomes, mortality specifically. So when we're thinking about homeless mortality, we actually don't have any national tracking of how many people die while they are unhoused. There's nowhere on a death certificate to indicate that. And so as a result of that, state and local jurisdictions have started to try to fill some of those data gaps and build our understanding about who is dying while unhoused and what are they dying from. So across the country, we have states and counties and cities really doing whatever they can to figure out what mortality looks like for this population. And consistently across those more local levels, we're seeing some key primary drivers of deaths for this population. And that includes drug toxicity, so overdose, cardiovascular conditions and events, so things that are related to hypertension, other cardiovascular events. Those are also leading causes of death for this population. And then two things that we see pretty clearly for the unhoused population that don't really rise to the top for the housed population includes transportation-related injuries and exposure-related causes. So motor vehicle and pedestrian deaths are quite common for this population. You know, a lot of the pictures that Emily was showing, you know, tents are on a sidewalk really close to a road. So if people are having to move all the time, walk everywhere to get the services they need, there's greater risk for transportation injury. And then similarly, hypo and hyperthermia. And across all of the state and local data that we have, it is clear that folks who are unhoused are consistently dying anywhere from 10 to 20 years earlier than their housed counterparts. So an extremely high number of years of potential life lost. So my dissertation, which I just defended a couple weeks ago, was looking at violent deaths by homelessness status. So CDC has a national violent death reporting system. It's a statewide or state level reporting system that tracks homicide, suicide, legal intervention deaths, deaths of undetermined intent, And they have a variable for homelessness, which is fantastic. So I looked at unhoused violent deaths and housed violent deaths across the country over a 17-year period and calculated a partially age-adjusted standardized mortality ratio and found a mortality ratio of 12.9. So people who were unhoused experienced almost 13 times the number of deaths that would have been expected if they were similar to the housed population. And that translates to about 245 excess unhoused deaths per 100,000 people. And I think this is important to note that the kind of context of homelessness that Emily was talking about for infectious diseases, that kind of context of vulnerability and structural vulnerability applies to violence and other chronic conditions as well. So this is showing the violent death rate ratio comparing unhoused population to the housed population in the US over a 17-year period. And I'm kind of just now putting together that this trend actually looks similar to all the other line graphs that Emily has shown thus far. So we can see that folks who are unhoused experience a disproportionately increased rate of violent death, and that has been increasing over time. So in 2021, the rate of violent death for unhoused folks in the US was 19 times higher than that of housed folks. So I'm not going to spend too much more time going into these data, but do just want to kind of paint this picture that it's not just infectious diseases. It's kind of this broader context of structural vulnerability that does have severe consequences like death. So I'm going to pivot to talk a little bit about kind of the federal landscape and what's going on right now. And I think that maybe one of the most concrete ways to do this is to look at one of the executive orders from July of 2025, focused on ending crime and disorder on America's streets. And so in this executive order, it kind of packaged together discussions around homelessness and housing, addiction, and mental health. And so this EO really called upon four primary agencies, and that's Health and Human Services, so SAMHSA, HRSA, CDC. It called on the Department of Housing and Urban Development, and it also called in Department of Transportation and Departments of Justice. And it really kind of set directions for policy and funding. And there are three kind of big things that I think are worth noting from this executive order, and that is the shift from housing first to treatment first, this kind of elimination of harm reduction, and just a general kind of restriction in funding for homeless service response systems. So I'll talk very briefly about these three pieces and what they mean. So housing first, if you're not familiar, it's an approach that emphasizes housing without precondition of sobriety or engagement in treatment. The idea is that if you get someone into housing first, then they can focus on getting enrolled in behavioral health treatment and care. But that really kind of the core is that someone needs to have a stable place to stay before they can think about, any of these other engagements in care. And so housing first has kind of been the standard approach for federally funded programs for quite a while now, at least a decade. And so this executive order is saying that's not working. We're not going to do that anymore. We're going to focus on treatment first. And treatment first, by contrast, emphasizes that people should be engaged in things for like in addiction treatment, in care for mental illness, and then they can worry about housing later. And so in that executive order, there is encouragement for civil commitment and this idea of tough love, that sometimes folks need to have a wake-up call and be arrested to realize that they want to make change in their behaviors. So homeless services and housing programs that employ housing first approaches, which has been the federal kind of standard thus far, now are at risk of losing their federal funding if they use housing first approaches. And funding is changing every day for health programs as well. Service providers are losing money left and right for supporting this population if their activities are deemed to be, quote, harm reduction. So shortly after that executive order last summer, SAMHSA came out with this Dear Colleague letter, and it says that SAMHSA funds will no longer be used to support poorly defined so-called, quote, harm reduction activities. And so I think it's just worth noting that even this Dear Colleague letter acknowledges that harm reduction is, quote, poorly defined. And so who knows what kinds of things they're going to be looking at and considering harm reduction or not. And as a result of that, recipients of federal funds that are implementing a range of services might have things that are flagged as harm reduction and they're at risk of losing their funding. So, for example, Healthcare for the Homeless, or HCH grantees, they receive HRSA funding and provide care to around 1 million people who are unhoused or at risk of homelessness each year. And so, for many of those people, Healthcare for the Homeless programs are their only kind of form of healthcare and their primary engagement with care services. And so those services are threatened, and it means that over 4,500 healthcare sites are at risk of being shut down with this kind of changing federal landscape. And then in terms of the homelessness response system, it's estimated that 170,000 people who are in permanent supportive housing, meaning that they've recently exited homelessness, they are at risk of losing that housing and facing displacement. And it's estimated that with these kind of federal changes, it's possible that upwards of 45,000 people might be um, three kind of big things. First, the substance use research that might mean that those programs that are funded may not align with evidence or best practice related to harm reduction. And this also is likely and so there are going to be greater health needs for this population moving forward. So now I'm going to pass it back to Emily to talk about your specific context in Northern.
Great. Thank you, Ashley. Thanks for that that overview. So let's look at some Northern New England specific data. Ashley, if you go to the next slide, this is from the Alliance to End Homelessness. They have a 2025 report that has a lot of great information that's state specific and also national. But we don't have the numbers for 2025 yet on the national level. So this is actually from 2015 to 2023. Northern New England states actually had the largest percent increases in rates of homelessness per 10,000 people over that time span. That's not to say that we had the highest rates or the highest numbers, but we had these largest percent increases. So if we go to the next slide, the national numbers data don't have 2025 numbers, but so each state did have their own report. So I pulled out numbers for 2025 for each of the states for Maine, New Hampshire, and Vermont. And it's a little jumpy here because once we get into smaller numbers, things get things get a little jumpy. But on the whole, we are seeing that both sheltered in the green and unsheltered in the orange homelessness have risen in the past 5 years. The trends are clearer in New Hampshire and Vermont. New Hampshire's rise has been lower, but it's pretty steady. Vermont's high rise has not been subtle. And then Maine did, what I've gathered is that Maine did a bit of a strange counting right after the pandemic, and then got a bit of a jump in there that might not be real, but on the whole, I think we're landing still at a higher place than it was before. So generally, we are seeing, these rises over time, and it is most acute in Vermont. These are raw numbers; they're not rates here. And so you see that upper boundary there is 4,000. Vermont's population is the smallest, and these numbers are incredibly high for such a small state. So let's go to the next slide. Okay, and everybody knows it too. So the state health improvement plan for Vermont, goal number 1 is to improve the availability of affordable, accessible, and safe housing. It is a huge priority for Vermont. And if you click, Ashley, it's goal number 2 for Maine. Healthy and stable housing is really high on the list. And go ahead and click again. And also, For New Hampshire, they haven't written it quite as clearly, but it's called Access to Opportunity is one of their top priorities in their state health improvement plan as well. And that includes housing. So it's very high on the list. People are aware of it as a major issue. And an area for us all to be working on related to health. Go ahead to the next slide. I wanted to give a specific example of something that's going on right now in New England, in northern New England. And I want to go to Bangor, Maine. There's about 400 to 500 people experiencing homelessness there. That's a really rough estimate because it's not broken out specific to the city. But just keep that in mind as we go to the next slide. There has been an HIV outbreak going on in Bangor, Maine for the past 2 years. And at this point, this graph goes all the way up to April 2026. So this is very recent information. It's continuing. There are now 41 cases of HIV. And if we go to the next slide, this group, these cases are 90% in people who are experiencing homelessness in Bangor. So these slides are from our colleagues at Maine CDC and Maine Health, and this information is, it's publicly available, and it's just so striking. So I wanted to share this as a specific example of the risks that we have in northern New England. Because, well, let me go to their next slide and show their takeaways. The conditions in Bangor are not unique. That is a major takeaway that they have. They're not unique in Maine, and they're not unique, they're not different from what we see in Vermont or New Hampshire. We could have the same thing happen. It's not necessarily that we think the outbreak in Bangor would spread to other places, but we have the same underlying contexts that are occurring. So you can see what they're saying here is that there's an increased risk of HIV in Maine. The homelessness crisis is fueling the HIV outbreak. And their takeaway here, I think, is incredibly important that social, housing, and health sectors need to work together to contain the outbreak and prevent further spread. So I wanted to highlight that specific outbreak because it is continuing. There is still work to be done there. And as we go into our next slide, we can start to think about, opportunities, just like what they're saying about this cross collaboration. When I mentioned that my supervisor in Alaska had said that we have these, recurring outbreaks among people experiencing homelessness. And I thought we should probably do something about that. And I continue to think that. So that really inspired a lot of the work that we did at CDC to start thinking about what do we do with this risk context, knowing what we know, with the risks that we have just gone through, we need to act here. And something that they say in the homeless service sector and HUD, they say we want to make homelessness rare, brief, and non-recurring. And healthcare and public health and research, that doesn't quite fit what our role might be. So instead, I would add that we also want to make it survivable because we need to have people survive to be able to make it out the other side of homelessness. So go to the next slide, Ashley. When we think about opportunities, I want to have us all keep in mind some key concepts. One is understanding what our role is. Like I said, it might not be our role to end homelessness, but we do have a role, and knowing what that is very important. Keeping the context in mind, so all of that I described in mind, and incredibly helpfully going out and talking to people and volunteering and being in the context will help keep the context in mind. And then full disclosure, I and Ashley, neither one of us are healthcare providers. We are PhD. I'm a PhD epidemiologist, and so w when I speak about clinical care options, it is more conceptual because I'm not a clinical care provider. But National Healthcare for the Homeless Council is an incredible resource. So I would really encourage anyone that's interested in thinking about best practices and models for clinical care to check them out and also reach out to them. They are super responsive. Ashley is very connected, and so you could just pester Ashley and she'll get you right connected with them, and they love to help. So if anyone is inspired and wants to, jump into some problem solving based on this, that is a great place to start. So Ashley, you want to go to the next slide? Okay, as I mentioned, we need to keep in mind what our role is in this system. Homelessness is a systems level problem. It is hard, and that's part of why I think sometimes we feel futility. We feel like we can't do anything about this because one person or even one sector by itself can't. We can't do it alone. We have to all be pressing levers. But we all have to do it. So we need to know what our role is and what the levers are that we have. This is a very simple graphic, but it basically just outlines this kind of nest of services and really kind of touch points that we have with people experiencing homelessness. Healthcare is, right in there. And then disease prevention is what I would say is, the public health role. And then we've got homeless support, which is shelters, outreach, and then homelessness prevention, which is more housing. So each of these little pentagons is a different sector, but we all need to figure out what we can do within our sector that connects to the larger picture. So some ideas, Ashley, if you want to go to the next slide, we can frame opportunities for what we can do based on pieces of the context. So I've just pulled a couple pieces of context out to kind of give some framing for where some best practices come from for healthcare provision. Ashley's going to talk a little bit about research options. But one of those pieces of context is that people often don't come to traditional healthcare settings. There's a lot of reasons for that. A lot of times they can't get to them. A lot of times they can't book an appointment. There's a lot of reasons, but we cannot have the expectation that people are going to come into a clinic. So some best practices that have come about over time are street medicine teams, mobile clinics, and also co-locating clinics with other services. So clinics that are co-located with shelters or with other housing navigation services is a great way to be able to get people in the door as low barrier as possible, just so that you can acknowledge the context of people aren't going to come to you, kind of have to go to them. Next slide, Ashley. Okay, another part of the context here is that people have experienced trauma. Trauma and homelessness are so intertwined. And that trauma has occurred both within and outside the healthcare system. But it needs to be acknowledged, and opportunities for addressing this and working with this are building trust through provider consistency. I remember I worked with an outreach organization. I was on the board of an outreach organization in Atlanta, Georgia, and they said it took an average of 7 times that an outreach worker had to talk to a person before they might engage in the pathway towards housing, because that trust had to be built. And same thing with healthcare. We need consistency to build trust. And sometimes that's not possible. Sometimes it is the reality of healthcare is that we can't do it. And in those cases, we need to find trust. So if we're not able to build trust in the ways that work best, there are people that have trust built. There are outreach organizations, there are peers, that can help work with people and find people and help with follow-up. And then we also need to, decrease stigma and not just stigma, just assumptions, just assumptions among providers and staff that could be creating a barrier to building that trust. And then finally, people have needs that compete with medical needs, and we had to keep this in mind so much during COVID-19 when we wanted people to get vaccinated. Um, that was just really not high on people's lists of things that they needed to get done each day. So what we want to do here is acknowledge and help facilitate those other needs. So um, medical care can be an access point for housing. And so facilitating pathways to housing and housing navigation through medical interactions is a great way to do a no wrong door, kind of entry point. And then also ensuring access to multidisciplinary teams because people do have various needs, and the behavioral needs and the medical needs and the social needs and the casework. If the more that can be uh, integrated, the better for people who, you might not see as often as you would like, so that that can all be done at the same time. So next slide, Ashley. Oh, that's you.
Yeah. So I'm just going to share a few ideas for directions for applied health research moving forward in case you fall somewhere on the research spectrum. One of the first things that I am thinking about all the time is adding housing and homelessness indicators into data collection. So if you're already collecting health data, if you aren't already asking about housing or homelessness, consider adding that as an additional question to really understand what the health profile and health needs are for people who are unhoused where you are. We do have resources to help do that, which I'm happy to share later. Another common or another idea is to include people with the lived experience of homelessness in every stage of research processes. So even just in the questions that we are asking as researchers, are those the questions that are relevant to people who are actually experiencing homelessness? Are those questions going to help address their concerns and their needs? And then include them along the way and let them guide you. We meaning National Healthcare for the Homeless Council, I say we because they're so wonderful to work with. One common phrase that's used a lot is nothing about us without us. And I think that as much as we can try to incorporate that into our research, that will benefit us all. I have a few ideas for kind of thinking about the broader context as Emily was getting at. The first is considering housing interventions in clinical trials, and I think this could take two different forms. First, make an intervention or include an intervention that focuses on moving people from homelessness into housing and look at how various health outcomes change or improve or don't. And then relatedly, keeping people in their housing. So thinking about homelessness prevention through things like rental assistance or legal support for people facing eviction, focusing interventions that keep people in their housing and looking at their health outcomes compared to others who maybe don't receive that assistance can really help us understand how changing different pieces of the housing context will shape our health. And then thinking even broader at the bigger context, consider other economic interventions in clinical trials. And that can be things like direct cash transfers and also elimination of medical debt. I think both of those things help people on a path of sufficiency and stability. So those are just some of our initial reactions for directions for future research. And Emily, I'll pass it to you for this one.
Yes, absolutely. So, I started in my role in Vermont just over 3 months ago. So I actually have a lot of questions for you all. Um, I want to hear about your experiences in New England related to homelessness and healthcare, what homeless service organizations you all interface with. That was, overall, the content that we wanted to provide, that we want to make homelessness rare, brief, non-recurring, and survivable. And would just love to have questions for us. And if anybody is willing to answer these questions, we'd love to hear about it.
Awesome. Thank you, Emily and Ashley. That was so informative. I know that I learned a ton. If folks in the audience have questions, I would encourage you to go ahead and turn on your microphones and your cameras and ask them in the room. If you're not able to do that, go ahead and put them in the chat and we'll open up the floor.
And I'll just say, I'm going to stop sharing just so we can see folks, but I am going to put those 3 questions in the chat if you want some more time to mull on them.
That would be great. Thanks, Ashley.
I got one. Thank you for that. I guess, here's sort of an observation and a question. I'm not sure there's universal acceptance of homelessness as a public health issue. Maybe a social service, infrastructure problem, something. Tell me what you're trying to do to kind of make this more if we have to think about homelessness and improving health the same way we think about, vaccines and primary care.
Yeah, oh, well, thank you. And I completely agree with you. That is, I think when we originally made that little pentagon diagram, that was the reason, was to say we don't, I don't think public health and healthcare tend to automatically take ownership of homelessness because the outcome of homelessness is technically like owned by different sectors, by housing and homeless services. And so then it feels like there's this feeling of futility and we don't have any control of this and homelessness shouldn't even exist. We can't do anything about it, but we have a role. We see the risks are exorbitantly high. We cannot have a portion of our population that experiences risks that look like that. It's inhumane. And we have this role in public health and in healthcare to find where those levers are, find where those opportunities are. But Dr. Carney, it sounds like, maybe you have some ideas for how we make sure that people are aware of what the roles are for public health and healthcare.
I think it's kind of like what you're trying to do now. You're increasing the visibility and the conversations shine a light on it. And even if it's uncomfortable or we don't want to think about it, then you get more and more people engaged. So I appreciate that very much.
Thank you. I appreciate that. Ashley, did you want to add or do we want to go ahead?
I
No.
was just going to say, Jen, I think that's something that we hear from state and local public health departments all the time of like, what is our role? Whose role is this? Whose responsibility is this? And I really like to think about housing and health as a kind of mutually reinforcing cycle. So if you're not well enough to go to work and maintain your employment and maintain your income, how are you to retain your housing? So I like to talk to public health departments that, to Emily's point of like keeping it survivable and keeping people well enough to be able to engage with the resources they need to stay in their housing. Like by supporting people's health, we are supporting their opportunity for successful housing outcomes. That's all I wanted to add.
Thanks. Gary, go ahead.
You raised one of the questions that you raised on your last slide was rural versus I'm going to use the term urban. I mean, I think where you cross the line into urban or what if there's that much urban, in northern New England is questionable. But I wonder, are there really any shared um, potential solutions, or do we have to think in terms of the unique characteristics and cultures of each of the urban populations? Perhaps one size doesn't fit all in terms of how you would approach it. And is that being looked at to any extent in terms of how we might be able to go ahead and to turn around some of the homeless related health and healthcare problems?
Do you want me to go?
Yeah, go ahead, Ashley.
Okay, that's a great question. And I will say this kind of exploration of what like the phenotype of homelessness looks like in rural context is something that more people are talking about at a national level and trying to figure out like, is the context the same? Do we need to be doing things differently? Like, how do things differ? There are two things that immediately come to mind that I think apply really nicely in rural contexts that also extend in urban contexts. The first is this idea of like building trust and utilizing trusted messengers in the community. Like, I think that's true regardless of what setting you're in. It might even be more essential and necessary in rural contexts, whether you're housed or not. And then the second thing, I think to one of Emily's slides, that bringing services to where people are, so doing mobile outreach, co-locating things, I think that could improve the health for everyone in rural contexts, not just those who are unhoused, but especially those who are unhoused. So just wanted to chime in and say that yes, HUD, they have like a whole rural and unsheltered funding program underway right now that folks are digging into. So Emily, I don't know if you want to add anything to that or if I missed pieces of your question and comment.
No, that was great, Ashley. The other thing I was wondering if you're asking about, Gary, is whether or not I was kind of wondering if you're asking if we maybe don't want to make assumptions about who we're working with, and we need to gather information about who it is first. Um, Go ahead, where you're gonna.
No, I was just going to say yes. That certainly is a component of it, because my limited experience in working with a series of rural communities in different parts, in different regions of the state, there certainly are similarities, but some very, very unique characteristics, and how you communicate, how you address problems, or the basis for problems are often quite, quite different.
Yeah, absolutely. I think that definitely applies to homelessness too, and a huge reason why the trust needs to be built, or you need to find people with the trust so that you can get the real story of what's going on and what you're dealing with. I think about that HIV outbreak in Maine and think about how important that is with that outbreak to get an understanding of what people are experiencing, what the underlying conditions are, because we can't just assume, from the outside exactly what's going on. So it's a great point.
And,
Um,
and often with these rural communities, part of the trust and confidence is associated with working with them to be able to go ahead and to share with you what they are encountering. And secondly, to make certain that they don't feel that what they are is a study group for you.
Yes. Excellent point. Yeah, that doesn't go over well. That doesn't go over well anywhere. So, yeah, thank you. It looks like we have a question in the room.
Yes, so I'm Patty, and this is Hannah. We're UVM students. I'm a medical student, and Hannah's an undergrad. I'm happy to make some comments on the homeless service organizations, at least in Burlington. I've been fortunate enough to interact with Safe Harbor through community health centers, right? So, like, their outreach teams, and really thinking about a conversation that I had yesterday about like the number of patients that are seen in the Safe Harbor clinic, or the expectations of 16 patients a day versus when you're on outreach, like reaching that number is just so much harder. Um, so like those financial aspects that really undermine the homeless services. And then when you extend that outside of this like urban center to those rural spaces that even the idea of co-locating, as like great as it is just like so much harder because you're reaching some of these like fiscal limitations here. So it's just one of my thoughts. But I guess one of the things that I'm sort of wondering, it seems like a lot of times we kind of fall onto this mortality space where we're talking a lot of these like very final outcomes and less about the morbidity data. And some of the pieces that I think are where clinical medicine sort of starts to play this preventative role of like stopping those worst outcomes. So when I'm thinking of like infections or sort of those cost reducing strategies, and I'm curious if you have any thoughts on like what like people are like, I guess both why mortality has been the priority there, and if there are any data streams that should be utilized more in at least speaking to the morbidity in this same population.
Ashley, I know you have thoughts, but let me just briefly jump in. The thought you're having about this the genuine logistic and financial spread when we try to reach people and we're trying to go out to reach people. I was very recently just thinking about this. I don't have an answer. I don't know. But I think that's a great area. Like, yes, let's identify that as a struggle and then let's identify solution. Let's think more about it. Let's not give up. I think is what I would say. Because I was just like, oh yeah, that's tricky. On the mortality thing, something an epidemiologist I worked with before liked to say is that in population health in general, we lean on our bookend data because it's our strongest data. Birth data and death data is our best recorded data in public health. Infectious disease, we're really lucky because we have really clear reporting for infectious disease cases. Other conditions we don't have as well recorded, and it often takes, different types of bigger studies, specific studies, and also I'm an infectious disease epidemiologist, so we leaned heavily on infectious disease, and then Ashley did her dissertation on mortality. So our presentation was biased because of who we are. So I wanted to just throw that out there. But Ashley, you want to go ahead and share?
Yeah. I'll actually say that we actually know there's actually very little data on the mortality side, but to Emily's point, just a reflection of the work that I do and what I'm steeped in, that was a feature. I will also say though, so that first recommendation for researchers of adding housing and homelessness to existing health data, like that's really one of the things that we're trying to push nationally right now. So we have syndromic surveillance data from emergency departments, urgent cares that are, feeding in to nationally. We also have national notifiable diseases and case reporting systems and whatnot. So we're trying to get housing variables and homelessness variables into those data sets and establish some common ways of measuring homelessness there so that we can get a better sense of what the full kind of population morbidity is looking like. But we don't know what we don't measure. So that's where we're starting.
Thanks.
So much. We are at 1 o'clock, so I know that folks probably have to jump off. I want to thank you all for your attendance and thank you again, Emily and Ashley, for that fantastic presentation.
Thank you so much. It was so good to meet you all. I hope we will
You
keep
as
in
well.
touch.